So these are the three pathways, as I mentioned before, and I'm going to start by looking at the pathway that discharges patients to skilled nursing facilities. And while I know that that isn't a lot of you who mentioned that that is where you currently work, I'm going to guess that if you're working in a hospital setting, this is a place to which you discharge patients significantly. And if you're a primary care physician, I'm going to also suggest that many of your patients are being discharged to skilled nursing facilities. You may not even be aware of it, and you may be the recipient of that patient or resident when they come back to the community. The goal for so many is to go to a skilled nursing facility and then to be returned to the community, and that isn't necessarily something that happens. And for those of you in private practice, those relationships become disrupted, and I think it's important to try to figure out how we might be able to put those back on the right track. So the first element in discharge is medication management, and this is true regardless of what setting we're sending someone to. But many of the patients that we are discharging from a hospital setting, particularly Medicare patients or people who are chronically ill, were on medications before they got to the hospital. You've either added or changed medications while they are in the hospital, and now they're going home with a bunch of scripts, and they have to try to figure out, or going to a skilled nursing facility with a bunch of scripts, and we have to try to figure out whether or not where they are ending up will be able to take care of their medication needs. And we often don't think about this when we're sending somebody to a skilled nursing facility or a rehab facility. We mistakenly believe that the word skill implies that it has a pharmacy, and that pharmacy operates 24 hours a day, as it would in many hospitals. And we assume that medications will be available for the first dose that is needed post-discharge in the new facility where the patient's ending up. That's not true. So for many of the facilities where patients end up, and this is also true when they go back to their home, the medications are not readily available for the next time when we are expecting them to get a dose of medication. If you're discharging somebody on a Friday to a facility that doesn't have their own in-house pharmacy, you may not have them receiving that medication until Monday morning when they receive their pharmacy delivery. If that's a maintenance medication that was not necessarily significant to creating a blip on the radar screen of their health, that may not be a problem. But for many patients, you had them on a medication that was sustaining them in a state that was necessary for stability. And interrupting that, particularly cold turkey, for 48 hours while medications are put back on track can be very deleterious to that patient, and they often end up back in the hospital not within 30 days, but within 30 hours. Those are the really quick bounce backs, and very often it's a medication issue for a bounce back. Transition planning is something that could really help us. Next slide. So, next slide. So the other important piece about transition planning is really understanding what was your expectation as a hospital in what sort of care plan this person needed as soon as they were wheeled out from your front door. Were you expecting them to have additional testing? Were they going to have consultations? Were there therapies that were required for them, whether it was OT or PT or speech? Did they need nursing services to change or debride a wound? What sort of interventions were necessary? And that sort of transition planning is really important. You can see beside on the right-hand side of that slide a tool from Interact, which is about interventions for skilled nursing facilities, where one of the things that gets missed all the time is an understanding of what are the capabilities of the facility you're sending a patient to. And when you take a look at those capabilities and you realize, well, they may have OT and PT, but it's an outside service that has to be ordered, or they may only have an external pharmacy, or they don't have a physician on site on a regular basis, or respiratory therapy, or psychological services for someone that you're discharging with a behavioral health issue, and then that patient becomes too unwieldy for that facility to manage, and their easiest recourse is to call 911 and send that patient back to you. Next slide. Next slide. So if you're lucky as an organization, whether that's a primary care practice or a hospital or even a family, something that could be really important for you in your transition planning is getting to know the facilities that you are sending patients and residents to. I'm often amazed at the number of times I will hear from a physician or from a hospital social worker that they've been discharging patients to a particular facility for years and years. They've never been there. They've never met the staff. They have no idea what their intake process is, and they have no idea what the capabilities are of that particular facility. And when the patient bounces back and they find out that the reason was pharmacy or therapy, or they did not have the appropriate ability to debride a wound properly, then you wonder why we didn't invest that time up front for a tour of that facility, or at least some meeting between the staffs. And for those of you who are old enough to remember, there was a time when social workers did a lot of this work, and they were able to start discharge planning early on in an admission, and they would include a visit to the facilities, and they had particular facilities that they sent patients to, and they really knew them, and they were able to make sure that the placements happened in a way that allowed for more stability. We're discharging patients earlier. We're discharging patients with less time between the notification of discharge and when they are out the door, and sometimes this is a step that gets missed. But understanding the facility capabilities and setting expectations is really important. If you're prescribing a medication as a physician that requires lab values in order for the medication to be set at the right dosage, you may be surprised to find out that many skilled nursing facilities do not have on-site lab and do not have, within their per diem rate, they do not have the willingness to pay for those lab tests that will be necessary as often as you think they are necessary in order to check a particular medication level. That's something that needs to be negotiated in advance. So we're going to have another poll question here. Next slide. Those of you who are in a hospital setting, and now I would assume for most of you who are in a primary care setting, you have electronic health records. I'm curious to know, for whatever setting you're in, whether or not you still work off of paper health records, have electronic health records, or a combination of the two. And we'll wait to gather those answers. Okay, and here are the answers. Oh, this is a major change over time. Only 5% of you have paper health records exclusively. About 2/3 of you have electronic health records exclusively, and about 27%, close to 1/3 of you, still have a combination of paper and electronic health records. 5% of you said others. I'm curious, but we don't have the time to go into it. But essentially, this is a major transition, that you have electronic health records. Now, the issue is whether or not the facilities that you are referring patients to also have electronic health record capability. I'm sure that you are familiar with the transition of care forms in electronic health records, but there is oftentimes a mismatch between the receiving organization and the sending organization as to the format of the information. Next slide. And this becomes incredibly important as we're transferring records for patients, particularly complex patients. So we may be transferring the complex medical records of what has occurred with that patient during the hospital stay, but are we always remembering to send the advanced care plan? Whether that's a POLST or a MOLST, physician order for life-sustaining treatment, whether that is just a DNR order, whether that's a living will. Are we transferring those pieces of information as we give report on the patient that we're transferring? And is there additional information that would be helpful to the receiving facility? Whether that was how many hospitalizations this person has had. Is this a chronic condition? Was this a diagnosis of a new condition? So all of those things become really very important as we transfer information. Next. And then importantly, what's the follow-up care that is required for this patient? Is the hospital now no longer going to have any connection with this patient? Or are they going to require transportation to a primary care physician or a specialist for follow-up within the community? And if so, who's responsible for making those sort of arrangements? If you assume it's the family, or if you assume it's the facility, they may assume in turn that it's your responsibility as a hospital to have set up those appointments in advance. And very importantly, to try to consider transportation and escort arrangements that might be necessary for some of these patients. They may not be able to show up to these appointments. So, next slide. And then the question is, what is the team, what is the healthcare team that is going to be engaged to liaise between the patient and family? Does the patient or family still think they can call the hospital for additional information? Are you turning them over to their primary care physician? Is it the responsibility of the receiving physician? All of this can be negotiated or at least discussed, and then the expectations have a better chance of being met. Next slide. And so why is this all important? It's important because we're now in an era of shared accountability. So now it is no longer that the responsibility of the hospital stops when the patient leaves their facility, and it's no longer the responsibility of the skilled nursing facility just when they show up on their doorstep. And the family and caregivers is probably the only constant across the whole board, but I will tell you that families and caregivers have an expectation that when their family member is in a facility, the facility is taking responsibility for the 24-hour-a-day care, and they are there to provide family support and socialization, but not to deliver care. And if there's a different expectation that they are supposed to be delivering care or coordinating care or calling the PCP or making arrangements for durable medical equipment, that has to be communicated to the family and the caregivers. And then what are the early warning signals? Does a hospital have a particular early warning signal for this type of patient that they want them to be careful of? For the condition that we're sending this patient in, please let us know if they develop a fever. Please let us know if they have swelling in their ankles. What are those early warning signals that you are asking for a shared, at least pick up the phone and call us before you call 911. We can shed some light on that situation. And what is the communication or transfer tool that is going along with this individual? Is there a way to capture the early warning signs? For those of you who are familiar with Interact, there are S-bars or tools that allow you to capture the situation, the background, what are the interventions, and what are the reports that you might want to make, what are the recommendations. We've listed there something called CS ACT, Condition-Specific Assessments and Communication Tools, that we'll be happy to share the concept with you. But it is around developing shared expectation about when hospitals are appropriate for this patient. What's in the advanced care plan? What's in the next steps that you want for this particular patient? And why this is important is because you're all now sharing, or will be sharing, in both the benefits and the penalties that come along with these rehospitalizations. If you're a skilled nursing facility, you might not see those penalties that I said before as being your responsibility. But when hospitals stop contracting with you because you are the ones that constantly return patients, they may realize that you're not the facility that has the skill for them, and they may be referring patients elsewhere. So it does have a downstream effect on skilled nursing facilities and rehab. You're going to have more shared accountability than ever before. Next slide. And again, very quickly, the interventions to reduce acute care transfers from skilled nursing facility. These tools have all been developed and all exist in the real world. Decision support, advanced care planning, quality improvement tools. We'll be making some of these available to you after the webinar. Next slide. Next slide. And then there are a whole range, as I said, of communication forms that people can use to indicate a change in condition. And these are forms for the frontline staff. These are not necessarily forms for physicians. One of the things that I neglected to mention before is there's a mismatch in our expectation of what staffing looks like in a skilled nursing facility. They're not mini hospitals. They are not staffed for the most part 24/7 with doctors or even with RNs in a same ratio that you are used to in the hospital. The frontline staff in skilled nursing are certified nurse assistants and licensed practical nurses. These are people with very little training relative to what you're used to in a hospital setting. And those are the people who are on a daily basis, an hourly basis, responsible for very complicated patients that came from a hospital. Next slide. These are some tools that we have developed here at the Pittsburgh Regional Health Initiative to help those frontline staff be able to capture and communicate changes in condition in a way that physicians are able to then act on them, as opposed to wading through hours and hours of documentation, just providing them with the high-level facts and the decision points that are important for an immediate response from a physician, so that the response is not call 911 and transfer them. Next slide. Up until now, we've spent a lot of time talking about Pathway A, which was moving a patient from the hospital to either a skilled nursing or rehab facility before they even went home, if they were to go home at all. When we take a look at Pathway B, we're talking for both those of you who are in urban settings or in rural settings, a very common occurrence, which is for a patient to go from the hospital home with some home health care, and then the hope is that they would stay home in the community and be transitioned to their primary care provider. So we have the same 7 issues on the right-hand side of your slide, and we're going to populate them very quickly, and I'm not going to go through the same level of detail, but I will point out some differences for you. So relative to medication management, we're really talking about some of the same issues. What are those medications that will be continued, discontinued when somebody gets home? And for that, there's a major part of the assessment that will be done by a home health professional, but it becomes really important for patients to understand whether or not they are adding a medication or they are discontinuing a medication from home, etc. And they will be doing this primarily on their own without a lot of help other than a home care nurse who may be coming in for periodic meetings over the course of their first few weeks at home. Transition planning takes place with the home care agency, where there's need for coordination and identification of what are some of those key issues that you would want the home care provider to alert either the primary care provider or the hospital if they are to see an issue occurring with a patient. But one of the most important things in transition planning for somebody going home relates to durable medical equipment. Is there equipment that is required to be used in the home, whether that's a special bed, whether that is some rehab equipment, or whether that's an IV that will be used in the home setting? Has that equipment been ordered? And if so, will it be set up before the home care nurse gets there? What will be the disruption in care because we are transitioning someone to a home setting? Very often, providers will make sure that that durable medical equipment is in the home before the patient gets home. Similarly, that medications are available before the patient gets home. But the most important piece of these transitions when you're going from a provider setting to a home setting, with or without home care, is the assessment of the patient and caregiver's strength and capabilities. Their education and engagement is paramount to the success of any transfer to a community-based setting. You have to make sure that your materials, since you're no longer dealing primarily with educated providers, are at the education level of the family. And that doesn't mean lower level education, but it may certainly mean lower level health literacy and understanding of what is expected of them. And this can't be done just at the time of discharge. It has to begin early. Many of us remember a time when discharge planning began with an admissions packet in the hospital. It would be helpful if we went back to such a setting, such a stage, so that we would understand what families are capable of doing, how well aware they are of what responsibilities they're going to have when this patient is transitioned home. They're going from 24-hour skilled care of people in a hospital, providers, doctors, nurses, ancillary services, home to maybe a home care visit 3 or 4 times a week, and the balance of the 168 hours a week is going to be the responsibility of the family. That's a tremendous burden, and you have to understand what they know and what they can do. Similarly, information transfer. Transferring information from a hospital to a home health provider is not that big of a deal. However, making sure that the information you provide to families is understandable and well structured requires a completely different set of instructions and a completely different thought process. And we often forget to include the primary care physician in that conversation. Does the primary care physician even know that this individual was hospitalized and that they're coming home with a new treatment plan? Whose responsibility is it to contact that primary care provider to update them or to schedule any follow-up visits with them or any specialists? And what is the follow-up care plan? How many appointments? With whom? Is there transportation available? It is very helpful oftentimes as a best practice to set up the first or second appointments with the providers before you discharge a patient to the community. Once they get home, the family is exhausted, the patient is exhausted. By the time they can get through to that operator at the doctor's office, while you have a provider-specific line, they go into the pool with every other patient, and you may have told them how important it is to have this visit within the first 2 weeks. They may not be able to communicate that sort of urgency themselves to the receptionist, and you may be able to do that on their behalf, or charge the home health provider with making sure that that's an activity that they take care of in one of their first or second visits. And very importantly, shared accountability. And the reason why this is so important is the readmission penalties and the overutilization penalties, they're going to be a shared responsibility going down the road. The primary care doc, it's hard to hold them accountable for a readmission for a patient that they didn't even know had an admission in the first place. So organizing and sharing information becomes really very important. Where does the role of the home health provider stop and the role of the primary care physician start? Those things need to be discussed, if not negotiated. Next slide. So Pathway C is very similar to Pathway B, and we'll populate it here completely for you. What you're missing here in the middle is a home health provider. So when the patient is leaving the hospital, it is between the hospital and the family and the primary care physician to take care of all the post-discharge needs. Now, some of that may be simple. The hospitalization may have taken care of the issue. There may be nothing that is required to be done other than to communicate with the primary care physician, give them an update on information and expectations for follow-up visit. But there again, that patient and caregiver education becomes critical. If you don't have a home health care provider in between here, whose job is it to get the durable medical equipment? Whose job is it to understand the new medication schedule? Do they now have two medications that do the same thing but have different names? And now we need to make sure they're not taking that twice. And very importantly, with both this and the previous pathway, does the advanced care plan get reviewed and communicated with the home health provider, with the primary care physician, and with the family member? So these are very important issues, and for many of you who are working with just primary care practices, closing that information loop, finding out if there is even caregiver education and training that is available will become very key to establishing successful partnerships to avoid readmission.